And we're live. Okay. All right. Good morning. Okay, so we have a storm coming. I will not be working tomorrow, so if you have any issues, email me your issues and I'll get to it when I can. I don't know what's going to happen with power and things like that, so give me a little bit of time to get back to you if you email me. Everybody stay safe in the storm. Okay, before we get started on today's lesson, I want to go over something that comes up quite frequently and at this point in the course. You guys are getting ready to take your test and get certified. And that's kind of on your mind, right? Because test time is right around the corner. We only have a week left. So a lot of you are thinking about other certifications to add to your CNA. You know, what should I get? And this is a question I get all the time. Should I get my phlebotomy? Should I get EKG? Should I go get a med tech? You know, what other certifications should I go get? And the answer is none. You need to figure out where you're going to work. And if you just go take all of these certifications, there are no places that are going to hire you that need all of those certifications. A lot of CNAs think that they need a lot of things under their belt to get hired somewhere because you're going to be in demand just with a CNA. You don't need to add anything to it. And when you start taking these other classes, it can really add up in cost with no real benefit to you. It's not going to raise your pay. It's not going to open up additional doors. If you go to work in a hospital, you'll never use a med tech. They have nurses for that at the bedside. If you go to work in assisted living, you're never going to use an EKG or phlebotomy. Good morning. If you go to work in an Alzheimer's unit, they will give you the Alzheimer's training. Okay, or sponsor you to get the Alzheimer's training. So when you go out and you get all of these certificates, you're never going to work in a place that requires all of them. So that means that you've wasted money, and most of those have to be renewed, and that costs money. But you also have to prove that you're working in a place that you use it in order to renew it. Does that make sense? And I've seen a lot of people just throw money away, especially with phlebotomy. That's the big one. Everybody wants to take phlebotomy. There's no benefit to it. If you want to work as a phlebotomist, go to work for the blood bank. They'll train you. Okay. But the phlebotomy and the CNA don't go together. They're two totally different career paths. So adding a phlebotomy to your CNA isn't going to benefit you. Does that make sense? Now, in some hospitals, very few, but some hospitals, they do have their CNAs phlebotomy certified. Those are very few and very far between, and they're going to require that you go through their training because they want to make sure that you're trained appropriately. Especially with phlebotomy, phlebotomy is not about drawing blood. Everybody gets that wrong. You know, putting a needle into a vein takes maybe an hour to teach you. It's a 6-week course. We're going to do an hour on putting a needle into a vein. So what do we do with the rest of that time? That's where phlebotomy is really, the training is going to focus their time on. Putting a needle in a vein, IV drug users get this down and they're, you know, completely out of their mind when they're doing it. It's not a hard skill. Does that make sense? But knowing which tubes to use for which tests, there's 100 tests. How do you know which tube to pull out for that test? That's what you're going to learn in phlebotomy. How do you prepare that tube? What do you do after the blood is in it? Do you chill it? Do you heat it? Do you spin it down and separate it? What are the additives in the tubes? Those are the things that you're going to cover in phlebotomy. Now, if you're working in a place that doesn't use phlebotomy and you go get your certification, it's not really going to benefit you. Okay. Now, the other one I want to talk about is MedTech. And we were just talking about this a few minutes ago. MedTech is in Florida, a 6-hour program. It's just a certificate. It's one day. You go there, you listen, you prove that you can do what they taught you to do. You get your certificate and you're off and running. And a lot of people that are going to work in assisted living try to get their MedTech before they get into the assisted living setting. But most assisted living are not going to take a chance on a brand new employee and give them the keys to the narcotics cart. Can you see how that could be a problem? You're a new employee. They don't know you. They have no idea what your motivation is. Are you there to be a med tech, or are you there to divert medication for your own use? Because you are a unknown employee, they usually won't hire med techs off the street. They will take their current employees and train them, people that they already have trust in. Does that make sense? So when you're talking about going and getting other certifications, my suggestion is figure out where you want to work first. Go apply, go interview, and ask them, are there any additional certifications that I need prior to coming to work here? Or do you provide additional training for certificates that I'm going to need? And you'll be surprised, most of them are going to provide training for you. Okay, so that's my money-saving tip of the day. All right, so we have chapter 7 that you read. Let's see here. Good morning, everyone. Oh, so Uganda has a storm going on. Well, best wishes to you. I hope you stay safe. All right, so page 187, you read chapter 7 in the yellow book, took the test on page 187 in the white book, and then graded it. When I call your name, let me know what grade you got or how many you missed. Ada? 1. Okay, thank you. Zumarinda? Elvira? 2. Thank you. Robin? Robin, do you have 4, 5, and 6 for me by any chance?
Yeah, 90, 85, and 90.
Thank you. Samantha? Thank you. Samantha, do you have 5 and 6?
I have 5.
Okay. Thank you. Janiyah? 100? Do you have 5 and 6 for me?
Yes. None.
Thank you. Catherine?
95.
Thank you. Jihu?
0.
Thank you. Paula? Kaylee? Brianna? Kiara? Thank you. Cheyenne? Tamika? Jody? Abigail? Did I miss anybody? Okay. All right. Oh, Young, you do not have that book. If you go to flcnatraining.com, let me put the link in the chat for you. There's a link there to order the books if you need any of the books. So I don't think I've got it on there. So hold on one second. CNA training.com. So go to flcnatraining.com and we've got links to both books in there. Thank you, Tamika. I appreciate that. So I'll write that down. Okay. So this is the last review we're going to do. This is it. Next week, we will not have reviews. So if you struggle with any of the things that I'm about to say to you, make sure you go back and rewatch this review. Okay. So we're going to go through all of the principles and the skills we've learned so far to make sure that we have those principles down. We're going to learn 3 skills today. There will be time for practice at the end of the class. And next Monday, we only have 3 skills left. That's it. So you're almost done. Almost done. You guys have done very well. So skill rules, we perform the skill as directed on the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. So we don't change it. While we're there, we're going to observe for any abnormalities, changes, or pain, and we report those observations off to the RN. Every skill starts with an opening, and every opening starts with a knock. Then we're going to greet our patient and address them by name. We'll introduce ourselves by name and title, describe the skill, get permission, close the curtain, and then wash our hands. It has to be done in that order. No deviations. Once you've washed your hands, then you can go get your clean supplies. Remember, you can't touch the patient or your supplies until your hands have been washed for that skill. Doesn't count that you washed them in the last skill. Different cooties, different patient, different everything. So don't touch your patient or your supplies until your hands have been washed. If we're going to use supplies, we have to think about gloves. We're going to use gloves if we're going to touch body fluids, personal skin, or non-intact skin. So wounds, rashes, sores, incisions. The first thing your gloves should touch is the patient. That prevents cross-contamination. Once you have touched the patient, though, now your gloves are dirty. You don't want to touch a lot of stuff in the environment, so pay attention and remove your gloves correctly. So pinch up at the palm, pull off, and they go under at the wrist and pull off. If we're going to use supplies, we need a barrier. That barrier will provide a clean area for our clean supplies, and we're only going to touch our supplies with clean hands. Don't let the supplies touch your uniform. It's not clean. And you always want to get that barrier first. So we do our opening, we wash our hands, we go get the barrier, put it on the table, and then we go back and get the rest of our supplies. That way we're not holding those supplies against our uniform while we try to spread out the barrier. Privacy blanket is going to be used anytime the patient is uncovered or undressed, and it's used for warmth and privacy. Remember, the rooms are cold, and if you take that sheet away from your patient, they're going to feel cold and exposed. So the privacy blanket helps prevent that. We put the blanket on over the sheet and pull the sheet down underneath so the patient is not uncovered at any time. They're always covered with something. But when we put that blanket on, we don't want to snap it or shake it. We just want to lay it out. If we use a privacy blanket, you want to remove it at the very end of your skill after all of your supplies have been taken care of and your gloves have been removed. So the privacy blanket is the last step we do before the opening. Good? Linen rules, most of these are repeats. We already know this. The linens can't touch your uniform. You have to have clean hands to get your linens. We don't snap or shake linens. But then we got some new ones here. Clean rolls toward me, dirty rolls away. This is a way of trying to prevent cross-contamination between a dirty item and a clean item because the undersides are all that touch. Okay. Don't let anything touch floor. Clean, dirty, doesn't matter. The only thing that should ever touch the floor are your shoes. And then anything that you take and don't use must be discarded. If we're going to turn a patient over, we have to remember that that patient needs to be in the middle of the bed after the turn. So if you use side rails on the state exam, they don't count. You can use them, but they don't count. Your patient still has to be in the middle of the bed. Whether or not you use side rails or not, doesn't matter. Your patient has to be in the middle of the bed. So in order to make that happen, we scoot our patient toward us, and then we roll them away from us. And we always stay behind, the patient's behind. And we make sure after the turn, the patient's in the middle of the bed. If you remember on class 1, I told you that the hardest job I had was to get you to stop thinking about the test and you and your performance on the test and start thinking about the patient. If you remember me saying that's my hardest job, well, this is what's going to illustrate that. Because you're going to think to yourselves, okay, I got to scoot the patient toward me, roll them on their side. If you don't stop and look at that patient, if you just do the steps, scoot toward me, roll away, and you don't look to make sure that patient's in the middle of the bed, the steps don't count if they're not in the middle of the bed. Okay, so that's the important part here. They have to be in the middle of the bed after the turn. So when you turn a patient, stop and look at them and make sure they truly are in the middle of the bed. If not, roll them back on their back, scoot them a little bit closer to you, and then roll them back on their side. Washing rules. We have a lot of washing skills, a lot. And all bathing is done the same way. We don't put soap in the basins. Basins are no soap zones. That keeps our water clean for rinsing. To get water, we're going to use a paper towel to turn the water on and check it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. And we're also going to ask our patient to check it. If we're going to wash a wet body opening, eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions, any area where the skin is not intact, you need that leaves method, where we hold the washcloth in the diamond and we fold the leaf over with each body opening that we wash. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get your surface wet, so protect the bed with a towel, or protect the table or the floor with a Chucks. And then if we put lotion on, we warm it up in our hands, put it on, and then wipe off the excess. All basins are cleaned the same way. We just rinse it, dry it, and store it. Nothing interesting here, other than after you rinse it, you want to set it down in the sink and use a paper towel to pick it up. Because if you did disinfect it, we can't touch it with our dirty hands or dirty gloves after we've disinfected it. So rinse it, dump it, set it down, paper towel to pick it up, and then dry the inside, dry the outside, and use a paper towel for the drawer. Shoe rules. Now we're going to talk about this again today. This is one of the skills that we're going to be going over today. If the patient's feet hit the floor, we got to talk about their shoes. So we actually have to say something if the patient's feet are going to be on the floor, like, do your shoes fit appropriately? Are they tied snugly? For this skill that we're going to learn today, we actually have to put shoes on the patient because we're going to transfer them from bed to wheelchair. So we want to make sure that we're saying, I'm putting your shoes on. Slipper socks are never enough. If we're going to use a gait belt, when we put it on, we always want to check it with 4 fingers to make sure that it's snug enough. Don't ever have it too loose, because it's totally ineffective and can actually cause injury. Before we lift a patient, their feet must be flat on the floor. And once we do lift them and get them standing, we want to ask, are they dizzy or weak? If they are, sit them back down, make sure they're safe, and go get a nurse. If we do walk a patient, or if we're putting them in a wheelchair, we always have to stop and make sure they can feel that chair behind their legs before we sit them down. It's a very important step. Otherwise, patients will stiffen up and they'll become resistant because they're fearful. So we always want them to feel that chair behind them so that they're more compliant. And we want to use those proper body mechanics. 1 foot in front of their feet, 1 foot beside the chair at the corner of the box. That way we aren't pulled off balance when we're lifting a patient toward us. And then the closing. There's lots of C's to the closing. Make sure they're in a clean and safe environment. Address their preferences. Do you want a magazine, head of the bed, whatever. Ask about comfort. Give them their call light. Open their curtain. Make sure they're covered. I should never see knobby knees. We've talked about that. I shouldn't see knobby knees. And then open the curtain and wash your hands. If you have to document, documentation is always after you wash your hands, but then you have to wash your hands again because we want to make sure that we end skill with clean hands and that our patient feels cared about as well as cared for. Good? All right. We learned how to take a pulse. A pulse is simply a measurement of how many times the heart beat over 1 minute. And we do that by finding the radial pulse at the wrist. So it's way up here where the thumb comes off of the hand at the bendy part of the wrist where the lines are. Never use your thumb, 2 fingers. We're going to put our 2 fingers in place using our fingertips, not the flat part, the fingertips. And we're going to put our thumb on the back side to hold consistent pressure. We're going to count for however long the care plan tells us to count. Whether it's 60 seconds or 15 and multiply by 4, whatever our care plan says. And normal pulse rate is 60 to 100. For the test, you have to say start and stop when you start counting and stop counting so they can see how long you're counting for. And so the evaluator can get the same number, hopefully. But you can be off by 4 beats in either direction. You will count with both evaluators for this skill. And it's a documentation skill, so make sure you document. Dressing a resident with a weak arm. Good morning. Good morning, everybody. Dressing a resident with a weak arm. We want to ask about clothing preference. Patients have the right to choose their own clothing, and we're going to get that clothing before we undress them to minimize the time that they're undressed. We're going to lift from below with a flat palm. So if we're lifting the leg, always from below. And we're going to support all joints when lifting. We remember this by USA first, which is undress strong arm first, and then dress the weak arm first. We don't want to overextend or force movement, and then we'll adjust that clothing for neatness. Make sure all the buttons are buttoned right or snapped right. Make sure the pants are over the hips and the socks, the toe seam is lined up. We'll put all the dirty items in the hamper, and then the call light goes in the stronger hand. Hand and nail care are pretty easy. We're going to support that hand and wrist as we move it. We're going to soak the hand in water, take it out and put it on a towel to wash it. Put it back in the basin to rinse, put it on the towel to dry. Clean under the nails with the orange stick, beveled end. Wipe off that orange stick between nails. And then we'll use an emery board to file the rough edges in one direction only toward the center. We put a lotion on last, warm it up, wipe it on, use a towel to wipe it off. Making an occupied bed. This is really kind of a magic trick. Change the bed with somebody in it. And all we're doing is changing the bottom sheet a half at a time from side to side, not top to bottom, side to side. But in order to do that, you've got to get your patient laying on their side in bed so they take up less space. So scoot them towards you, get them on their side. We're going to take that dirty sheet, loosen the corners, roll it toward the patient, because remember, clean rolls toward me, dirty rolls away. So roll it toward the patient, put the clean sheet on, roll it toward us, tuck that under the dirty, and we've changed half of the bed now. Get the patient back on their back, go around to the other side of the bed, repeat. Put the top sheet on, change the pillowcase, make your hospital corners. That's the whole skill. The big thing here is safety. Make sure that the patient is in the middle of the bed at all times. When you change pillowcase, the opening really should face away from the door, but that's not a graded checkpoint. Side lying position. If you have to turn a patient on their side and they cannot help, this is a procedure we can use to make it easy on them and us. Scoot them towards you. Furthest arm goes up, closest arm goes over, closest knee bent, furthest knee angle. Up, over, bent, angled. And then you just simply roll them on their side. We'll use a pillow behind the back in a roll to keep them on their back or on their side because they are going to want to try to pull back onto their back. One pillow between the legs, specifically between the knees and ankles. One pillow under that upper arm to support it. And then we're going to adjust the pillow under the head to make sure it's not under that shoulder. Call light goes in the bottom hand. Foot care, just like hand and nail care, a little lower, nothing with the toenails. So we're going to put the barrier on the floor, the basin on the floor, put the foot into soak, take it out to wash, put it into rinse, take it out to dry. The whole reason you're there is to look. It's the whole reason you're there. Look at the foot. You need to say something in the test like, I'm looking at the foot. We're going to apply lotion everywhere but between the toes. Wipe off that lotion, put their shoe and sock back on. That's foot care. But remember, the whole reason that you're doing this is to look at that foot. So if there's any toenail problems, redness, wounds, sores, rashes, athlete's foot, anything you see that are like, that doesn't look right, make sure you report that to the nurse so the podiatrist will see that patient. Mouth care. Don't overthink this, guys. You're brushing somebody's teeth. Get them in an upright sitting position. Protect their clothing with a towel. Wet the toothbrush, put some toothpaste on it, and brush. After you brush, let them rinse as often as they need to. After you rinse, dry them off. And then you're going to dispose of all of your supplies. Make sure at the end of the skill, your patient's mouth and clothing are clean and dry. Respirations, you don't want to explain to the patient what you're doing. We're going to say vital signs instead. Respirations, just like pulse, is always reported over 1 minute, but we'll count however long the care plan tells us to. You will count with the evaluators, but they'll count at the same time you do. So you don't have to do this one twice. Normal respirations is between 12 and 20. We're going to tell the patient we're taking their vital signs, not counting their respirations. In and out counts as 1. We're going to say start and stop. And again, this is a documentation skill. Melissa's got some questions here. Can you put petroleum between the patient's toes and behind their ear lines? Again, you would forward that question to the nurse for that patient. We don't do anything without an order. Nothing. And petroleum between the toes, as a nurse, I would say no, because it's going to hold in moisture. Warm, dark, moist. Now, if your patient has a very specific situation where they need that, it would be reflected on the care plan. And if you're talking about oxygen tubing, putting petroleum jelly on, because it can irritate the back of the ears, you can't use petroleum products around oxygen at all. So I would absolutely say no to that. But again, go by your nurse's recommendations for that patient. All right, range of motion. CNAs do exercises to retain function. Remember, we're just trying to keep what's there, not make it better. We're going to lift extremities from below with a flat palm, 2 points of support near the joints. Move slowly and smoothly all the way back to start. Flexion extension is up, down. Abduction, adduction is side to side. And rotation is around. Follow your care plan. Denture care. You guys see how much we've learned? Oh my goodness. You've learned a lot. This is all review for you. Denture care. So we're going to put a washcloth in the sink. We'll use cold water or cool water. After we clean the dentures, we'll store them in a denture cup filled with cool, clean water and put that on a paper towel as a coaster. The patient must be sitting fully upright to do mouth care. We're going to protect their clothing. We'll brush all surfaces of their mouth, usually using a toothette rather than a toothbrush. And we'll wet the brush before we apply toothpaste. Allow the patient to rinse and spit and leave the patient's mouth area and clothing dry. Ambulate with a gait belt. We learned this on Monday. Your whole focus here is to pay attention to the patient. So we'll apply the gait belt while the patient is sitting. It goes over their clothes around their waist. We're going to help them to stand by holding that gait belt on both sides or around the back, and we're going to let the patient lead. We'll walk slightly behind and to one side. Your attention should be totally on that patient at all times and ask how they feel frequently. We're going to assist the patient as we stand them up and sit them down using that body mechanics technique. 1 foot in front of their feet, 1 foot beside the chair. Have their hands on your shoulders and lift them to a standing position. And when you're ready to sit them back down in the chair, same body mechanics. And we don't want to pull that gait belt against the skin where it can burn the skin. This is the last skill that we learned on Monday, partial bed bath, the longest skill that we do. But there's nothing new here that you really need to learn. It's just a washing skill. And the care plan tells us exactly what to wash. We're going to wash face to waist, front and back, one arm and hand. We're going to wash the face first, no soap, and we'll use the leaves method on the face. We'll control the washcloth during cleaning, no floppy corners anywhere. And we're going to support the arm at the elbow as we lift it to clean. We'll change that water if it gets cold or soapy. We'll turn the patient on their side to wash, rinse, and dry the back, give them a little back rub, wipe off the lotion afterwards, and then put the sheet back on, remove the towel, tie the gown, and do your closing. There's not, it's a long skill, but there's nothing new to it. Okay. Good? Good. All right. So today we have 3 skills to learn. We're going to learn how to transfer a patient out of bed and into a wheelchair. We're going to learn how to feed a resident in a chair. And we're going to learn how to do Peri care, which is personal female cleaning in their personal area. We'll talk a little bit about male Peri care as well, but that's not on the test. All right, so if you look at page 72, we're going to transfer a patient from bed to wheelchair. So remember all of those things we just reviewed, right? You have all of those. So all of those banners are actually in your book at the beginning of every single skill. On the screen, I just put blanks in there to quiz you. Those blanks are also on here on the flashcards. But you can make your own. Just write it out and put a blank. If you can fill in the blank, you know the principle. Along the side, you'll see the principles that are involved in this skill. This one is going to have skill rules, opening, glove rules, shoe rules, and the closing, along with the skill specific. Again, there's a video for this. If you look at the bottom of the screen, you'll see test specific information. So for this skill, we're just going to take somebody out of bed and put them into a wheelchair. That's the skill. Take them out of bed, put them in a wheelchair. They give you 11 minutes to do that. Take them out of bed, put them in a wheelchair. They give you 11 minutes. That is, I have never taken 11 minutes to put somebody in a wheelchair ever. So I want you to slow down for this skill. This skill is 100% safety. Every step on this has to do with safety. And safety is graded really big on the state exam because you might be the best transfer in the world. I mean, you can get somebody out of bed and throw them in a wheelchair super quick. But if you're not doing it safely, if your patient gets injured, it doesn't matter how good your transfer was. At the end of the skill, your patient was injured. So slow down for this skill. It's going to be a live testing patient. That means you might be a patient for this skill. And the patient will start out in bed. So if you look at the top of page 73, you'll see the care plan. This care plan tells us to transfer the resident from bed into a wheelchair. The resident is unable to walk or take steps. You want to underline that or highlight it. It says they are unable to walk or take steps. So that means if you don't get that wheelchair close enough to the patient and you stand that patient up and pivot them around, if they have to unconsciously take a step back to find that wheelchair, you did not follow the care plan. So you want to make sure that wheelchair is super close to the patient because it tells us the patient cannot take steps. But it does say they can stand with support, so you're not going to be holding somebody up that whole time. A gait belt or transfer belt is required to transfer the resident, and the resident will stay in the room. You got step-by-step instructions here. Along the bottom, you can see the supplies that you'll need. But this isn't a really hard skill to learn. I want to review the shoe rules, though. If the patient's feet hit the floor, we have to talk about their shoes. Well, in this case, your patient's going to start out laying in bed. They're not going to have shoes on. Nobody has shoes on laying in bed. So you're going to get them sitting on the side of the bed. And once you get them sitting there, you actually have to put their shoes on. So during the test, remember those evaluators want to be at home in their pool drinking their margaritas, right? They don't want to be watching you tie shoelaces. That's just not really what they want to be doing. So they're going to try to make this a little bit easier on you in most cases because they don't want to be there. So during the test, they have to match you up with somebody your body size or smaller when possible for this skill. Now you can do this on somebody bigger than you, but for the test, minimal skills competency, which means they're going to try to match you up with somebody your body size or smaller. And they're going to look around. So let's say that all of you guys are here to test. Okay. And when you came in, I checked you in and I asked you, do you have any conditions that would keep you from being a patient for any of these skills? And all of you said no. Thank you. And you have a transfer out of bed and into a wheelchair. So as you guys are all getting checked in, I'm actually going to kind of look around and see who I can match you up with for this skill that's going to be your body size or smaller with slip-on shoes. So as you guys are all getting checked in, I'm actually checking out your shoes to see who I would match you up with because it's easier, quicker to just put slip-on shoes on for the test. Okay. So like your shoes are slip-on shoes. So you would be a good patient for this skill. And I would look around if you're doing this skill and just see, does anybody else have shoes that just slip on that I could put you with? Make sense? Okay. Remember, slipper socks are never enough. That is the most failed step on this skill. Whoops. When people are performing this skill, that's the step that trips up the most people. They will try to transfer a patient out of bed and into a wheelchair without putting shoes on. That is a failing action. You have to put shoes on before you transfer. Remember, the potential for injury here is pretty high. We're going to put a gait belt around the patient's waist, and we're going to check it with 4 fingers. Their feet must be flat on the floor before we transfer, and we're going to count to 3 to make them a partner. Once we get them standing, we're going to pivot them around, make sure they can feel that chair behind them before we sit them down. And then we'll make sure the feet are supported on the foot pedals. So you want to put the shoes on before you transfer the patient. So we're going to get the patient sitting on the side of the bed, and then you want to put their shoes on. If the shoes tie, they must be tied before transferring. Don't leave the shoelaces undone. Slipper socks are not enough. When we put the gait belt on, we put it around the patient's waist. We're going to check it with those 4 fingers. We're going to make sure the patient's feet are flat on the floor. Count to 3. Use that proper body mechanics, 1 foot in front and 1 foot beside as we lift them to a standing position. And then we want to make sure that they can feel that chair before we sit them down. So remember, I had you underline this or highlight it, unable to walk or take steps. That is the important part of this care plan. So that means when you're getting the patient ready to transfer and you get them sitting on the side of the bed, you get their shoes on, we put the gait belt on, your wheelchair is going to be way out here somewhere, far away. Because you can't have it close to the bed, we got to swing them around. Their feet will hit that wheelchair if it's too close. So we've got it way far away. Our care plan says our patient cannot take steps. So if we lift the patient up here and the wheelchair is way over here, that patient has to take steps to get to that wheelchair. What does our care plan tell us the patient can't do? Take steps. So for this skill, when you get the patient all prepped and ready for the transfer, you need to bring that wheelchair super close to the bed. I mean, within an inch of the patient. It's going to look like the patient is touching the wheelchair. It's that close. And that's the only way you can do this and prevent the patient from taking steps. Let's talk about brakes. Brakes are the most important part of this skill. Brakes work differently on different models. Wherever you go to work, you'll be trained on their wheelchairs. If you go to test and get this skill, they'll show you how their brakes work. But brakes either, there's a lever that controls the brakes. See that lever? It's either push the lever forward to engage the brake or pull it backwards to engage the brake. So when we're doing the test, you really want to know, how do I engage the brake for this? Brakes are super important. I'm going to explain that in just a second. But when we engage the brake, you've got this little metal bar here that when we engage the brake, see how there's a gap that lets the wheel roll freely. When we engage the brake, that metal bar bites into that wheel, preventing it from rolling. So this is how you find out if the brake is applied. Just see, is that metal bar pressing into the wheel? If it is, your brake is engaged. Brakes must be engaged anytime the wheelchair is not actively being moved. Actively. Now, the reason for that is safety. So, this is a hospital hallway. And if you look at the reflection of the lights, you can actually see a little bit of waviness. Now, that's because floors are not completely level. They're not completely level. In Florida, concrete floors tend to crack because they settle. Wood floors tend to warp because of moisture. Floors are not completely level. Now, if you put a patient who weighs something in a wheelchair on an uneven floor and you don't lock the brakes, if that wheelchair starts to roll and the patient can't stop it, the only thing that's going to stop that wheelchair is whatever they run into. Could be a wall, could be a piece of equipment, could be another patient, could be a door, or even down a set of stairs. If you have a patient in a wheelchair and that wheelchair is not locked, the potential for injury is high. This is not a restraint. If the patient can go, if they're able to propel themselves and stop themselves, they can undo the brakes and go anywhere they want. It's not a restraint. It is a safety measure. Let me explain to you how important this is. This is one of our biggest lawsuits here in Florida. This happened in 2004. We had a patient that was immobile, could not move on her own. She was a dementia patient, and she was strapped into a wheelchair with a gait belt, which is not allowed. That's an unlawful restraint. And she somehow found her way out of an exit door to a stairwell. And she fell down that set of concrete steps. I want you to think about that for a second. You are strapped into a wheelchair, can't stop yourself from going, and you see this staircase getting closer and closer and closer, and you know you're going to go down. Can you imagine the terror if you weren't able to stop that wheelchair? That's horrible. That is 100% us. This was one of the largest, it's no longer the largest negligence. We've had some bigger ones since then, but this is one of the largest negligence lawsuits in the state of Florida. So this is something, when you have a big lawsuit like this, that standard is going to be reflected in the test. Okay? Because this situation showed that there are CNAs out there that don't understand how important this is. If the wheelchair cannot be stopped by the patient, then the brakes have to be applied at all times. Good? Make sense? Okay. Brakes are not a restraint. They're a safety measure. Anybody who can take care of, their own wheelchair will. Let me see if I can get this through here. But brakes are not considered a restraint. You'll actually have people that argue with you over that. They're wrong. All right, when you're moving a wheelchair, you kind of want to tip it up on its back wheels like this. The front wheels will get all kind of tangled up and keep you from moving it. So just tip it up a little bit to get the small wheels off the floor and you can move it. Wheelchairs are usually kept in the folded position like this. This is for easy storage. To open a wheelchair, there's no levers to pull, no buttons to push. It's all manual. Lift the back wheels up off the floor, reduce friction, and open the wheelchair. That's it. To close a wheelchair, you lift up on the center of the seat and the two halves go back together. Open and close. They don't always open and close this easy. This is an easy one. Some of them take a little more force, but pretty easy. Your brakes, right here, the rubber tipped levers. This is our brake. So there's one, rubber tipped lever, two. Now the brakes are applied. To remove the brakes so that the wheelchair rolls, I would just simply push those levers forward and now my wheelchair rolls freely. Good? Questions? Okay. All right. So again, we want to make sure that that brake is engaged and pressing into that wheel when you walk away from a patient for safety. That's a really good written test question. It's a really good written test question. All right, so I want to explain this to you because this, a lot of CNAs don't understand this concept. If this is this wheelchair and that chair, okay, so this is taken here. I got down real low and took a picture. Do you see how much higher that wheelchair is than the chair? That's because when you're sitting in a chair, we want your feet flat on the floor for support. But when you're in a wheelchair, we want to push you somewhere. We don't want your feet flat on the floor. We need that wheelchair a little bit taller so your feet dangle. That way we can get you where you need to go without your feet getting all tangled up. So wheelchairs are always a little bit taller, but that presents a problem because along the back of your legs, you've got arteries and veins. Arteries take blood to your feet, veins bring blood back from your feet, arteries and veins. And right here at the back of the knee, those arteries and veins are really close to the surface. Like in your thigh, they're buried super deep. In your calf, they're buried super deep. But at the knee, they're really close to the surface. So when you have a patient in a wheelchair and their legs are dangling, not supported on anything, just hanging there, that seat edge is going to press up into the backs of the knees and it's going to crimp those blood vessels. And this is what it's going to look like. So you've got a patient sitting in the wheelchair. This edge of the seat is going to press up into the backs of the knees, and it's going to crimp off the blood supply. Now, artery, high pressure system blood is still going to get to the feet. The problem here is that the veins are a low pressure system, and they're not going to let blood back to the heart. So now the heart has less blood to distribute, and we end up with swelling in the legs. Do you guys remember me saying what happens when blood slows down or stops? Anybody remember what happens when blood slows down or stops? It clots. So what we've done here is slowed down or stopped blood flow from going back to the heart. So this patient is at risk of blood clots. Make sense? So when you have a patient who is sitting in a wheelchair and their legs are just hanging down, without support, we have just increased our patient's risks of a lot of really bad things. So when you put a patient into a wheelchair and we close down those veins because their legs are dangling, this is what a vein should look like. There's little valves in here. Those little valves, because this is a low pressure system, those little valves shut in between heartbeats. So as the heart beats, these blood cells get pushed up into this chamber and this valve closes. So it's kind of like climbing a ladder. That's how blood gets back up to your heart to be recirculated. The problem is that when we have feet that dangle, those, oops, hold on, let me go back here. Where is it? Those blood cells, because this is all crimped, they can't get into the next chamber. So they stay in one place and they tend to clump together. And that's why we're at risk of blood clots. So when we have a patient sitting in a wheelchair, we have to make sure that their feet are supported on those foot pedals to prevent swelling and blood clots from forming. Good? Questions? All right, so there's two pieces to this puzzle. There's foot pedals and leg rests. So, I'll bring this over. So this is a leg rest here. Notice it swings out to the side. If I bring it all the way forward, it's going to click and lock into place. So listen to the lock. Hear that lock? I'm going to do the same over here. Hear that lock? Now, these leg rests are locked into place. In order to unlock the leg rests, to move them back out, there's a little catch back here on the back of the leg rests. You just pull the catch forward, and that moves those leg rests out of the way. Now, foot pedals fold down to support the feet. Foot pedals fold down to support the feet, and that's what you see here on the screen. You have foot pedals and you have leg rests. This is the position that your foot pedals and leg rests should be in when the patient is in the wheelchair. But we can't have this in place while we're trying to get somebody into the wheelchair or out of the wheelchair, because it's going to trip them up. So if we're going to get somebody into or out of the wheelchair, we're going to fold these foot pedals up, and we're going to move these leg rests to the outward position, and we're going to make sure the wheelchair is locked before we put somebody in or take somebody out. Remember, I said the skill is 100% safety. So this is an overview of what the wheelchair should look like. When a patient is sitting in it, the leg rest should be forward and the foot pedals down to support the feet. In storage, the leg rest should be forward and the foot pedals up to allow that wheelchair to collapse. If the foot pedals are down, they'll end up banging up into each other and the wheelchair will not close. During transfers, when we're putting a patient in or out of the wheelchair, leg rests up, foot pedals out. Or foot pedals up, leg rests out, sorry. This was horrible. This was super sad. This is somebody that was really trying to help. And it resulted in a lawsuit. So there was an older woman and her daughter that were in a facility. She went for, I think, x-rays. And nobody was available to take her out to the car. She was in a wheelchair after the procedure was done. There's a clerk, like a registration clerk, a non-clinical person. Transporter wasn't available. The daughter goes out, gets a car, pulls it up front. Patient needs to get in the car. Nobody's around to help. So the clerk thought, well, this can't, it's a wheelchair. I've got this. I can help. Got the patient out of the wheelchair and went to help them get into the car, but she did not fold the foot pedals up or move the leg rests out of the way. So now there's a tripping hazard right in the way. And the patient tripped and fell on the curb between the wheelchair and the car and ended up breaking her leg. And of course, they sued because this happened on hospital grounds. And that's the one place that we should not be getting injured. So this clerk felt awful. All she was trying to do was help. And I get that. But should we ever do anything that we're not trained to do? Even if we think we know how to do something, we should never do something that we aren't trained to do, because there's little parts here that you don't always know. There's an old saying, it's not what you know that gets you into trouble. It's what you aren't aware that you don't know. Because you don't know what you don't know. Okay, so be careful about this. This was super sad. All right. So when we're going to transfer somebody into the wheelchair, we'll prepare the wheelchair first by moving the foot pedals up and the leg rests out. Just like that. We're going to pivot the patient around so they're sitting on the side of the bed. And this isn't as hard as you think. To sit somebody on the side of the bed, where most people go wrong is they put a hand under the shoulder, which is right, but then they put one under the knee. This isn't a honeymoon carry. Instead, we're going to put one hand under the shoulder. That's correct. And the farthest shoulder should be in the palm of my hand. You got to get it all the way under. But this arm, instead of going under, is going to go over the knees. And then on a count of 3, it's just a pivot. Super easy. You can pivot somebody pretty easily. You can see there. We'll get them sitting on the side of the bed. We're going to get their shoes on, make sure they're tied appropriately. We're going to get the wheelchair close. And when I say close, I mean almost touching the patient. Engage those brakes. Make sure there's nothing in the way. Lock the wheels. Super important. We don't want that wheelchair to roll out. We're going to get the gait belt on. Now, it doesn't matter when you put the gait belt on. Whether you do it before you put the shoes on, after you put the shoes on, or when you get the wheelchair in place, does not matter. Just make sure the gait belt is on before the transfer. If the care plan calls for it. But let me explain to you why it's a good practice and why you should. If the patient can transfer themselves, we're not helping with this. Patient can get out of bed and get into the wheelchair on their own. We may have to bring the wheelchair over, put their shoes on, lock the wheelchair. But if we're not helping with the transfer, and care plan tells us the patient self-transfers, that's fine. But if I do have to help, I've got to have something to hold on to. I can't hold the patient's arms. That's lifting up here. Most of their weight is here. So I can't just hold their arms and pull. They're probably not completely dressed in the bed. So I've got nothing at their center of gravity to hold on to. And even if they are dressed, if you grab somebody by the pants and try to lift them up, have you guys ever had a wedgie? This is a monster wedgie. And they'll move. Oh, they'll move quick. But they're moving because you're hurting them, not because you're helping them. So in most cases, if you're going to assist this patient with a transfer, yes, a gait belt will be required. But it really, you always go by the care plan for that patient. Good answer for you? Okay. All right. So body mechanics are going to come into play here. I'm going to put my foot in front of his feet, the other foot parallel to the body. I'm going to grab that gait belt around the back or on the sides, have them put their hands on my shoulders, not around my neck. Just lay them on my shoulders. And then on the count of 3, we're going to stand up and swing him around. Now, he's got to feel that wheelchair seat behind him before I lower him. I don't want to hold him up while I'm asking that. It's a long time to hold somebody's weight in place. So instead of getting him in this position and say, hey, can you feel that chair behind you, and wait for him to say yes, I'm going to go back to here. And I'm going to tell him, okay, you're going to put your hands up here. I'm going to hold the gait belt. I'm going to lift you up and swing you around. When you feel that chair behind your legs, I want you to say sit. So when we get to here and he feels that chair, he's going to say sit, and then I'm going to sit him down. I'm not holding his weight for very long. A little preparation goes a long way with this one. When we get the patient seated in the chair, remember that chair must be locked. If this chair isn't locked, you know what's going to happen? When we try to put him in it, it's going to roll away. And now you're trying to hold a patient and chase a wheelchair, and everybody's going to fall. Everybody. Once we get them in the wheelchair, we want to get those foot pedals and leg rests in place to support the feet so their legs aren't dangling. We'll remove that gait belt, not pulling it across their skin. We're going to engage the brakes, because remember that brake has to be engaged if the wheelchair isn't currently in motion. Now, for the test, we're going to make sure that the patient is properly seated in the chair. Their hips are against the back of the chair. Their legs are fully supported. But you also don't want them facing a wall. Imagine for a second if I turned your chair around so you face the wall for the entire time that we're in here. You're not looking at me, not looking at anybody else. You're just staring at a wall. How boring would that be? You'd probably feel like you're being punished. So when you're putting a patient in a wheelchair, don't leave that wheelchair facing the wall. You need to turn it around so they're facing the TV or the door or a window or something for distraction, for entertainment. And then we'll do all of our steps to the closing. Any questions on this one? All right, I'm going to show you the video for this because it's got good close-ups. So we've got a lot of people out that need to, that are attending virtually. So I'm going to show the video because it does have really good close-ups. This one I normally do live in class, but we'll do video today. Come back. Thank you, Jacob. I appreciate that. Jacob says best training out there. He might be biased.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay. And I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders. Maintain a wide stance and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay. Can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay. Let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient. And we'll lock it into place. Okay, Mr. Jones, can you bring your feet together and slightly back? Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock your wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
You make sure that I'm up there.
After washing my hands, I'll think
Yeah,
about all the
that's,
steps of my skill, make any corrections,
the reasons that I
and
have.
tell the evaluator my skill is done.
So, without saying it out loud. Okay, can anybody tell me, other than you, can anybody tell me something that I said was important that isn't in the video? Yeah, to make sure that they can feel the chair behind them. So that is actually a relatively new checkpoint. So I'm redoing these videos in November, and the new videos will be out. But remember that when you turn a patient around and you try to sit them down, they've got to be able to feel that chair. So your book is correct. Your book has that step. The instruction I gave you in here is correct. But the video, while being correct, needs to add that step in. Okay? Good? Good catch. Okay. All right, so we're going to move on to feeding a patient now. This is on page 108 of your book. And you can see the principles involved here. So skill rules, we're going to follow the care plan. We're going to do the opening. We'll evaluate if we need gloves. We'll talk about gloves in a minute. We have to, barrier rules are going to apply, but we actually don't need a barrier for this skill because the food tray is our barrier. Linen rules are going to apply because we need a clothing protector of some sort, and the closing. So if you look at the bottom, you'll see you've got 9 minutes to do this skill, somebody with your level of experience. You will be a patient for this skill if somebody else has this skill, live patient skill. You will be positioned in a chair, and this is a documentation skill, so charting is required. So page 109 has our skill-specific steps. And at the top, you can see the care plan. Care plan tells us to feed a resident a snack who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. Underline that. Document the intake on a food and fluid form. So let's talk about this. There's a couple things about this skill that make it different from the other skills that we learned. So we're going to go through this one at a time. I'm going to sit because I need to illustrate something to you. Okay. All right. So feeding does not follow the rules. First thing that it doesn't follow the rule is that we don't use a barrier. Our food tray is the barrier. If you want to go get a barrier and put it on the table, that's fine, but we don't need it. The other, another way this is different than the other skills that we learn is it's the only skill we don't close the privacy curtain for. Eating is a social event. It's a social event. So imagine if you went over to a restaurant after class today and they put you in this little tiny cubicle all by yourself and pulled a curtain so nobody could see you eat. How weird would that be? Can't see other people, can't talk to other people. It would be very weird. Eating is a social event. We also have to have a conversation with our patient for this skill. It doesn't have to be a real conversation, but you have to have one. So you can say something like, do you want to watch the movie that's going to be playing later today? I think it's Casablanca. Or would you like to go to the activity room this afternoon? They're playing bingo. Have a conversation of some sort. And that's because eating truly is a social event. Think about all of life's celebrations. Baby showers, there's always food. Birthday parties, there's food. Weddings, there's food. Funerals, there's food. Graduations, there's food. Backyard barbecue, get-togethers with your friends, there's food. Food is essential to our socialization as humans. So when we're feeding somebody, if we're not having a conversation, if we're quiet and just doing this, it's going to feel very, very awkward for your patient. And they're not going to eat. They're going to take 2 or 3 bites and say, no, I'm done. I don't want to eat anymore because it's going to feel weird. Now, let's think about going back to that restaurant for just a second. If you walked into that restaurant, let's just pick on Cody's across the parking lot, right? Wednesdays are buy one, get one free fajitas. Go to Cody's. You go over there as a class, after class, and you walk in and there's 60 other people in there because buy one, get one fajita days are pretty popular. 60 other people in there, but you walk in and the place is dead silent. Nobody's talking at all. How uncomfortable would that feel? When we eat, we tend to have conversations. We don't talk with our mouths full, but while somebody else is chewing, you're talking. And then you swallow, or they swallow, and they start talking while you chew. So when we are gathering together with other people, conversation is an essential part of the eating process. So that means that we as caregivers need to be talking to our patients. That is an essential part of performing this skill. Does that make sense? Okay. And you are graded on it. You have to have a conversation for this skill. Now, for me, if I'm going to be spending time with my patients, there's a couple things that I do to make this easier, right? Because I don't know them, they don't know me. How do you start a conversation with somebody you don't know? It can get a bit awkward. So if I'm in their space, their room, their house, their whatever, in their space, I look around for clues. So anything the patient is willing to talk about will be on the wall or on the table or, displayed in some way. So if it's an older woman, I look around and I'm looking for a picture of her and her husband when they were young. And there's usually one, usually. And when I find it, I'll say something like this. Oh, Miss Mabel, those people on the wall, did you know them? Were they movie stars? Oh, they're gorgeous. Did you know them? Watch her sit up a little bit straighter
and say, oh no, honey, that was me. Now, what I've done there is I've made her feel good about herself. It didn't cost me a thing. I've made her feel good, which will automatically increase her appetite. But I've also given us an opportunity for a conversation. Wow, where was that picture taken? Tell me about your life. You know, that gives me some opportunity for further conversation. You can look around for hand drawings from children. Oh, who drew that? Oh, that's my great granddaughter. Oh, how old is she? So look in their environment, things that they have displayed for conversation starters. Now, if there's nothing in the environment, there are a few questions you can keep in your back pocket to kind of get a conversation started. My favorite question is, what's the most exciting place you've ever been? Now, I asked this question once many years ago, back in the 90s, and I was working with an older woman up in Citrus County, and she had extensive wounds on her legs. And this is like a 45-minute dressing change. I'm going to be there a while, so I've got to have a conversation. So I asked her, you know, what's the most exciting place you've ever been? And her response, you know, out of all the conversations I've ever had with anybody, this is the one that sticks out. Her response was, oh, honey, I've never been anywhere. Okay, so, you know, that kind of shuts down the conversation, right? And I said, you've never been anywhere? Like, we're in Citrus County. What do you mean you've never been any? Haven't you ever been to Ocala? And she says, no, I've never left the county. Whoa, wait, hold up. You've been in Citrus County for all of your 90-something years, and you've never once left this county? And she says, well, it's not entirely true. I was born in Brooksville, but I don't remember that. Oh my gosh, this is living history in front of me. Citrus County is a very small county. It's relatively rural. And here's somebody who's lived here for 90-something years. Can you imagine the changes that she has seen in 90-something years? She remembers when the first road was paved. She told me stories about two families in Inverness that were rivals. And the boy from one family was supposed to marry the girl from the other family and kind of smooth things over. But she ran off with a different boy. And that caused all kinds of chaos. She remembers when the first car dealership went in, when the first McDonald's came in. So the county had really changed a lot in her lifetime. And this is information I'm not going to get from some dry history book somewhere. This is life. These are experiences. So I actually went back to see her quite often. So here's somebody who doesn't think she has anything to contribute, and I still talk about her over 20 years later, almost 30 years later. So pay attention to the stories that your patients have. You never know what you're going to find out. I met a man that was knighted by the Queen of England. I met a pro baseball star. I met an engineer from the Apollo mission when we put the man on the moon. You never know what stories your patients are going to have, what lives they've led. So can you imagine getting to the end of your life and you've got all of these memories and all of these experiences and nobody is interested in hearing any of them? How sad would that be? Remember that our job is to make our patients feel cared about as well as cared for. And when you're feeding somebody, it gives you the opportunity to slow down, sit down, and have those conversations and connect with them as a human, not just a patient. Does that make sense? All right. So we do have to sit when we feed our patients. And that's why I'm sitting here to explain this to you.
When you are okay, I want you to see my position here. If I've got somebody standing here upright and they're feeding me, this puts me in a very dependent, inferior position. And I'm probably not going to eat very well. If somebody that's feeding me sits and now we're on equal footing and seeing eye to eye and they're having a conversation and treating me as an equal, my appetite is probably going to be much better. But if somebody's standing, I get the sensation that they're rushing and I'm probably not going to eat very well. So you do have to sit while performing this skill. Okay? And you have to have a conversation. So these are ways that feeding doesn't follow our normal rules. So remember I had you underline this in the care plan. It tells us in the care plan that your patient is in an inappropriate position for eating. No care plan out there is going to say that. They rely on your eyes to tell you that. But here's the problem. You could be a patient for this skill. If you're the patient for this skill, you're going to get some very specific instructions. You're going to be told to slouch or slump, and you're going to be told to only take 4 bites and then say you're full. No matter what the CNA says, just say you're full. So in reality, for the skill, you're only feeding somebody 4 bites of food. That's it. So they give me 9 minutes to do that. Lots of time. But the patient, the person playing the patient, will be told to only take 4 bites of food. But they're also going to be told to slouch or slump. Now, the problem is that your idea of slouching and slumping might be totally different from somebody else's. So some of you might do something like this. Okay. Has anybody ever eaten in this position? Probably, quite often. If you've ever met a 12-year-old kid, they all eat in this position. This, in your mind, may not be an inappropriate position for eating. And yet the person that's playing the patient was told to slouch or slump, and that's what they decided to do. Then you'll have others that do something like this, to make it very obvious. So I don't want you to pay attention to what your eyes are telling you during the test. I want you to pay attention to the care plan during the test. So the care plan tells us they're in an inappropriate position. That means you have to ask them to sit up straight during this skill. No matter what your eyes tell you, you have to ask them to sit up straight. Okay? Because our care plan says. We're going to offer them a hand wipe before we feed them. Now, I know we're feeding them. I get it. We're the ones getting this stuff on the spoon and putting it in their mouth. I get that. But it doesn't tell us that our patient is immobile. It doesn't tell us that our patient is unable to move. It just says that we're feeding them. And if you're feeding somebody and some food starts to fall, go ahead. You're good. You're good. Starts to fall out of their mouth. They may put their hand up there and try to push it back in their mouth. Do you want dirty hands up near a mouth when we're eating? So we really need their hands clean. But the other reason that you want to clean the hands is because hand washing is usually part of the eating ritual. Most people go wash their hands before they eat. So this helps stimulate the appetite, part of the eating ritual. So there's a lot of reasons why we want to wash their hands or give them a hand wipe before we feed them. We're going to sit while we feed the patient. Oh, we're also going to offer a clothing protector. They don't have to use it. We don't ever call it a bib. This is not a baby. We call it a clothing protector. Patient may say, yes, I'd like one. I need one. I can't eat anything without spilling half of it on me. That's just the way my husband laughs at me all the time. My dogs love it because they're the cleanup crew, right? So I need a clothing protector. Now, my grandmother, she was extremely prim and proper. If you asked her, would you like a clothing protector? She would get all haughty and say, I am not a child. So everybody's a little bit different. We're going to offer, but ultimately we're going to do what they wish, as far as clothing protectors. We're going to sit. while we feed the patient at eye level. And we're going to offer a drink before and every 2 or 3 bites as we feed them. Everybody has different preferences. We don't stop and think about this very often, but we all have different preferences. My aunt used to drink an entire glass of water before she ate anything. And she swore it's how she kept her figure trim, because she would fill up on water before she ate. Wasn't much room to eat, and it reduced her the amount that she ate. It doesn't work for me. I've tried. It doesn't work. But it worked for her. Some people like to drink with a meal. That's me. My mouth gets very dry, so I have to drink with a meal to make sure that everything goes down okay. And then there's some people who drink after a meal. Like my husband. He doesn't drink before or during, but he does drink after. So everybody has different eating idiosyncrasies. But it's not just drinks. We also have different eating idiosyncrasies, and you probably haven't stopped to think about this. Some of you eat all of one thing on your plate before moving to the next. Some of you take a little of this and then a little of that and then a bite over here and then a bite over there. And some of you are like, oh no, that's not how you eat. Some of you eat your salad first. Very common here. Some of you eat your salad last for digestion. Some people eat dessert first because life is short. Some people eat dessert last if they have room. Some people mix their corn and mashed potatoes. Other people don't like their foods to touch. So, the way that you eat is not necessarily the way your patient eats. And we have to understand that. Now, if you're a mixed corn and mashed potatoes kind of person, and you're feeding a patient and you just automatically mix their corn and mashed potatoes because that's what you do, and you try to feed somebody who does not want those foods to touch, they're not going to eat. So we have to understand this. Eating is extremely personal, extremely personal. So we have to understand all this in order to feed somebody adequately. Make sense? So we're just going to ask them, what do you want first? What do you want next? And we're going to let them lead. We'll do the feeding, but we're going to offer a drink before we feed them and every 2 or 3 bites as we feed them. This is why you're going to be told to only take 4 bites, because during those 4 bites, somebody should be offering you a drink. So we can get that check mark. Food should only fill the spoon halfway. That's it. So if you're trying to get this done quick and you're overloading that spoon and you're shoveling it in as fast as you can, that's not good. That happened when we were a testing center here. That actually happened. And the evaluator came out and she was like white as a ghost. And she's like, oh my gosh, this person almost choked, because the candidate, the person being tested, was overloading the spoon. It was chocolate pudding, and just as much on that spoon as she could get on, and shoving it into the patient's mouth super fast. So the person playing the patient didn't have time to chew or swallow. They were just getting more and more and more pudding. And the evaluator had to stop the skill because she was afraid. I mean, the person being fed was actually starting to cough, and she thought that they were going to choke. So we want to slow down. The spoon should only be half full, and you need to give your patient time to chew and swallow. Remember, it's not about us. It's always about the patient. Okay? So think about this, guys. If we're only feeding 4 bites and the spoon is only half full, we're only giving them a very little bit of, it's either pudding or applesauce that you get for the test. Very little bit. So we're going to have a conversation. Doesn't have to be real. Make something up. That's fine. But have a conversation. And we're going to encourage intake. So when that person gets to 4 bites and they say, no, I'm done, I don't want any more, we need to use at least 2 forms of encouragement. So I usually ask, are you sure you don't want just 1 more bite? And remember, if you're nice, you get further with patients. So I turn up the charm, try to get somebody to take a few more bites. and make them feel like I want to be there. If you go, oh, thank God, I've got a million things to do and 3 other patients to feed, and that's not the impression we want to give our patient. So I usually ask, would you like something else from the kitchen? We've all had those days. You get something, you take 2 bites, you're like, nope, not it, not what I wanted. So ask if they want something else. And then you can let them know that there's food available later if they want it. But you need to use at least 2 of those during the test to encourage your patient. Are you sure you don't want just 1 more bite? Would you like something else? And if you get hungry later, let me know. We'll leave the area around the mouth clean, just like every other skill, and we'll do our closing. Good? This is an easy skill. It's a super quick skill. I know they give you 9 minutes to do it, but it does not take 9 minutes to do this skill. But one of the things that we have to do with this skill is document. So this is a food and fluid intake form. You can actually see this in your book. Page 168 and 169 has these forms for you to be able to play with, document on when you're practicing. Details matter here. We're going to offer a hand wipe before feeding. We're going to offer a clothing protector. We're going to offer a drink before feeding, and every 3 or 4 bites, we'll let them lead. We're going to feed slow. The spoon should only be half full. And no childlike feeding techniques. No planes, trains, or automobiles. No zzz. No choo-choo trains. These are adults. All right, so because we have to document, that means we have to learn how to compute feeding percentages. This is going to be done on what we call a quarter scale. If somebody eats everything on their plate, they ate 100%. If they ate nothing on their plate, they ate 0%. And then in between, you have 75, 50, and 25. So if they ate most of what was offered, but left a little behind, then they ate 75%. If they ate half of it, they ate 50%. If they just picked at it, took a few bites, they ate 25%. So this is going to be an estimation. It's not like exact, it's an estimation. But we generally use the quarter scale as our documentation standard. Wherever you go to work, they'll tell you how they want food intake documented. But this is generally accepted. So if you look at on the screen, if you look at the images there, you can see that we have a sandwich, some broccoli, and some Jell-O. And the first one there, the patient ate, I don't know, maybe a bite out of their sandwich, a couple pieces of Jell-O, and 1 stalk of broccoli. So they ate a little bit. How much would you say they ate? Look at what they started with and how much they ate. How much would you estimate? Yeah, they ate about 25%. If you look at the next one, how much do you think they ate? 50%. If you look at the bottom one over there, that's 75. And then this one would be 100. Even though there's a broccoli stalk left and 2 pieces of Jell-O, we would give them credit for 100%. Broccoli stalks don't count. Ask any 10-year-old, they'll tell you. All right. So that's how we document food intake. Fluid intake is something different. For fluid intake, we actually measure. We measure fluids. And in healthcare, we measure in cc's or mLs. Cc's and mLs, same thing. Same thing, 2 different names. Cc's or mLs. That means that we have to learn how to convert ounces to mLs. Now, a lot of times our containers will actually do that for us. So if you look at your water bottle there, on the label, should tell you how many ounces. 12 ounces. Okay, now next to it in parentheses, it probably has mLs. Does it have mLs? 355. So the container actually tells us it's 355 mLs or cc's, same thing. So if you look at your Pepsi bottle there, how many ounces? 16.9. Now, in that same area, it should tell you how many mLs. 500. So the label actually told us. Now, if we're working with a cup that doesn't, a cup, something that's not prepackaged, we have to do the conversion ourselves. And the way this works is that 1 ounce is worth 30 mLs or cc's, 30. So if we have a 12-ounce cup of water, 12 ounces of water, we would multiply that 12 by 30 to get the amount of cc's. 12 times 30 is 360 cc's. Good. So yours was 355 cc's, close. We could do the conversion if it just gave us ounces. But if it gives us the mLs, we'll use the more scientific mLs. Good. So 6 ounces, we would multiply 6 by 30 and get 180. 8 ounces, we would multiply 8 by 30 and get 240. You will have a math question on the state exam. You will either have to convert ounces to cc's, or you will have to add up the amount of cc's that they took in for the shift. That's called intake and output. So 1 ounce is worth 30 cc's. And if you go to page 106, this is a worksheet that you can do. You can estimate the amount of food the patient ate, but in the second column toward the bottom, we have a little activity that helps us convert ounces to cc's. So the first cup there is 6 ounces of juice. How many mLs or cc's would that be? 6 times 30. Anybody? 180. So that would be 180 mLs. The second one is a milk carton, and it actually tells us how many mLs there are. So we always go by the carton when it's prepackaged. So this would be 240. And then the third one there is 12 ounces of coffee. That's a lot of coffee. 12 ounces of coffee, which is 12 times 30, 360. So if we had 180 of juice, 240 of milk, and 360 of coffee this shift, and it's the end of the shift, and we've got to total all of this up, we would add 180, 240, and 360 together to get our total intake for the shift. How much, somebody do the math, 180 plus 240 plus 360. How much intake? 780. That's right. So that would be the total amount of intake. Now, for those of you who are using your phones, please remember that during the test, you cannot have any electronics. So you have to be able to, they're going to give you a piece of scratch paper that you can, or a whiteboard that you can do the math on.
Do we have to use that? Or can we do it in our head?
You can do it in your head. That's fine. Yeah. And it's simple. It'll be like this, 2 or 3, it's not going to be like this whole list. But this is all intake and output. There are going to be some patients that we care for that we're going to have to monitor how much fluid goes in and how much fluid comes out. They should be roughly equal. You'll have a little bit of fluid loss for respiration and digestion, but minimal. They should be roughly equal. But if we have somebody that took in 1,200 cc's this shift, and they only peed out 200 cc's this shift. What happened to the other 1 liter, 1,000 cc's? It is still in that body somewhere. And that's going to cause swelling, or the water may be in the lungs, which could affect breathing, or it could be in the arteries, which will elevate blood pressure. So that extra fluid had to go somewhere in the body, and the nurse has got to figure out where it is and what kind of problems it's going to cause. So understanding intake and output is actually really important for CNAs. You will be responsible for measuring fluids that go into a patient and fluids that come out of a patient every shift, if your patient is on I's and O's, intake and output. Okay, good, good. When you go to work anywhere, during orientation, they're actually going to give you the measurements. They're going to say, okay, this is our water cup. Our water cups here are 6 ounces. This is our coffee cup. Our coffee cup here is 8 ounces. This is our juice. Our juice is 4 ounces. And they'll give you those measurements so that you know how much each one of those cup items that they use in that facility will hold. All right, so if you go to page 132, we're going to talk about medical abbreviations really briefly. You're probably going to want to do this activity and pay some attention to this particular lesson. I'm not going to cover it in detail. There's a lesson in the online program on it. You've got this worksheet that you can use. But if you look on this page, page 132, in the first column, you can see some of the medical abbreviations are highlighted in gray. Those are the ones that you absolutely positively need to know. It's highlighted in gray. You need to know it. Some of them at the top are going to be based on frequency. So QD would be every day, QAM is every morning, QPM is every night, Q2H would be every 2 hours, and so on. And a lot of students try to make sense of this and they can't. And the reason you can't is because it's not abbreviated English. It's abbreviated Latin. Latin is the language of science. It allows people from different cultures to communicate scientifically. So most scientific pursuits will document things in Latin. So the things that we use now are based on the standards that were put into place eons ago. BID means twice a day. And again, it's Latin. B stands for bi. How many wheels does a bicycle have? 2. So BID is 2 times in a day. TID, T stands for tri. How many wheels does a tricycle have? 3. So TID would be 3 times a day. And then you get down to QHS, which really messes people up. QHS is how in Latin you say bedtime. You know, it's basically quaque ora somni or something like that. But it just basically means at bedtime. Hour of sleep is the rough translation. And then you'll get down a little bit lower, about halfway down. I want you to look at the one that says NPO. NPO. Again, this is going to be abbreviated Latin. NPO means nothing by mouth. So this goes right along with our intake lesson. Nothing by mouth means that the patient is not going to eat or drink anything. Now, you may see NPO except water. That means they can have water, but nothing else. Or NPO except ice chips. It means they can have ice chips, but nothing else. So NPO means nothing by mouth. Good. You'll also see a few medical abbreviations that are in English. Those are the more recent ones. But this worksheet will help you put into practice how to use those medical abbreviations. NPO is the one that's most likely to show up on the state exam. Any questions? All right, so intake and output, page 169, I show you the form that you're going to be using for the test. It is a quarter scale for both food and fluid. On the, don't pay attention to that arrow. The one next to it, food and fluid, is going to be a quarter scale for the test. Now, if you're measuring fluids, you would use the one that the arrow is pointing to. If you're measuring fluids, and we're going to use that one on Monday when we empty a catheter bag, a drainage bag, and measure the contents. So you will be using the intake and output form for emptying a drainage bag. For feeding, you're going to use the food and fluid intake form. When you go to take the test, they are going to give you the correct form. They're not going to throw a curveball. They'll give you the correct form that you need. Good? Questions? All right, and page 107 tells you more about that whole intake and output thing. So let me show you this video. I don't have anything to feed you guys, so I have to show you the video on this one. And then we'll take a break, and then we'll get into catheter care. And the remainder of the class after that will be practice. What's that?
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Okay. Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate and the amount of fluid that they drank. Using my documentation form, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? Any questions? We only have one more skill to go, and that's catheter care. There's not much, or I'm sorry, peri care. There's not much that you need to learn about that. We know all of the principles. It's a washing skill. We know the patient's uncovered or undressed, so we need a privacy blanket. We know we need a barrier to put our supplies on. We're going to be in wet body openings, so we need gloves. We're going to turn our patient over, so we're going to scoot them toward us and then roll them away. You know all of the steps required for this. We're also going to use the leaves method of cleaning because it's a wet body opening. So we learned that on Monday. So there's not really much new to learn for this particular skill. But we do have to talk a little bit about infection control and the possibility of the patient developing a urinary tract infection because we do this the wrong way. So we're going to talk a little bit about the pathogen problem with peri care. And I'll show you how to do this particular skill as soon as we get back from break. But this is a pretty easy one once you get over where you're washing. Okay, let's go ahead and take our break. Come back in 15 minutes. And I'll see you then. Absolutely. Yeah, anything you need. Yeah, go to flcnatraining.com. And did you get the email I sent out yesterday about class today? Okay. So just go to FLCNA, it's on your syllabus, flcnatraining.com, and just click on class 6 and watch the last hours. Thank you. You're welcome.
You're still 16? Oh, I read some of it. Not all of it. I did the test. I do everything right. Yeah, I've never had an energy drink. I've only had soda like 4 times in my entire life. Okay, Oh, 118. Second. The way that the 15s are acting up, it's just going to move forward. Thank you so much. I'm sure I'll agree. So I'll probably say to okay. Just not turning for now. Bye. She's going to work. I really would have to work. I gotta leave at 12. You should sleep before you go to work. How the hell are you still up if you haven't slept in 2 months? Yeah. I know. Yeah, I took a lunch and right before I moved. Oh my god. When your kidneys are failing in 10 years, call me. I got you. They're already there. So hi, how you doing? Alright, let me close this. I came in late, so she kind of just said. And I came in on my normal time. I made 2 new friends in class. You have to refuses to turn on. Yeah, I left Brick House at a time where I should have gotten here like a couple minutes late. And I got here 5 minutes before the GPS said I would. I had drive. So. Oh wait, how many CCs did she say? 30. Yeah, I do math in my head really easily. 8 ounces of coffee. What's 8 times 3? 24, 240. That's how I was taught. Yeah. Works. Damn. Math was my favorite subject in school. It's so easy. English. I hated English. It was the easiest class in class. Every essay I had to write, I got a D or lower. Until like my last year of school. Which year was English? Yes. I knew English was I also stuck in science. Unless it was biology. I liked biology. Huh? Well, it's and, so it has to be a vowel. I don't blame you. You had a fucking slept. It is. You know, they did a sleep experiment when I was living in Russia. Oh,
Was it Russian? It was either German or Russian.
I think it was. I
Like
don't know
30
if I,
days sleep.
after like 5 days of not sleeping, they went crazy. I sent it to one of my other friends a while ago.
Or is it the Russian secret story? Oh, that's what it was. It's the Russian secret story. Please answer my own question.
Oh yeah, did you know about this?
So I don't do friends.
Sure, at the bottom of this will second issue forever. Yeah, I always forget to do these. Do you have a fourth one too?
Can I do that?
Well, I did most of them. I just didn't get the. Did I have the fourth one? Yes, they look at the third one. Like, I did the second one. Huh?
How do you not have the fourth one?
I wasn't here on Monday.
Oh, you overslept.
It wasn't anything that I overslept. I woke up and I was just like,
I know the Monday before class ends.
Why?
I actually know what to do.
Yeah, I completely forgot until about like noon that we were supposed to get wings on Monday. And I was like, oh shit.
When I didn't get to I'm gonna be so honest with you. I went home. I had to go get two. I
don't miss those shifts. But I went horseback riding on Sunday with my husband, and my horse had a butt on its butt.
Let's see.
Took a picture.
I remember spots.
Her name is Pokey. No, that's her actual. Yeah.
I'm interested in
I have her. I may not have been so very, but that's just because I'm not old enough. They only get a 18-year-olds. I always look at the answers, not to like get the answers, but to check myself to make sure I'm right. You want to say, uh-oh. Who knows? Don't God really have to be baptized? Okay, then I can do it. I'm not baptized. That's why I asked.
We got children. Children to the girl.
For the most part, I'm not really religious.
Yeah. I will make you I'm very much upset that he's doing this. Yeah, I told you my husband's a UPS man, right?
I mean, he is.
Taking pictures of your work to go back to high school. Yeah, me and my best friend used to always just take off each other's work. We'll do some of it, she would do some of it. I remember in my entry work class, there was this is the students in the chemistry class. We would do a different topic.
Well, it says the answers.
Well, it said manager associate oral chemistry class. What else you gonna put, right? Look at that player.
Make something up. Yeah, maybe.
That way you have class 6.
Yeah. Isn't that the next class or is that this class?
This class. So you work on because I'm not usually doing it, but I'm not that time to do it. Oh, I need to.
You know what's nice about copying yours rather than my friend Cat?
Right, and you
Yeah. I can barely read hers.
God, your handwriting is so bad. I try. My handwriting is like this.
Pretty much right half normal, half perfect.
Absolutely love it. I would have to read tonight. I already have the test done.
I should read tonight, but there's a hurricane heading in tomorrow, and I'd like to try to make some money before that hits. From yesterday's slice.
Oh, I'm working through the hurricane.
It's supposed to be category 3 with the lights.
It's Florida. It's a hurricane.
Yeah, fair. Look at how Sarasota flooded last time, though.
Look how see Pete and Tampa flooded. Yeah.
Well, a lot of people were saying that Sarasota never floods. But then I looked at where it is, and I was like, yeah, I don't know about that.
Try Riverview too. Evenings. Evenings.
I've never heard of that place. Citrus County.
That's why. Rule number 1, don't go to eat work. Rule number 2, go to shot.
That bad?
There was a shooting out there like last year.
Definitely.
So everything was a drinking party for basically.
There was a shooting at the Ocala Mall 2 days before Christmas, I believe, last year.
There was just a shooting at Citrus Park Mall like not even last week.
I've never heard of that mall. Mine is Paddock Mall. That's the only mall I got, and it's 40 minutes from my house. It sucks.
Citrus Park is.
We just got Target, though. That's nice. And we're getting 5-packs. I'm really I worked there for like.
14 per month.
Is it glitching like crazy?
So randomly from there. So was it just my phone?
Yeah, I guess it's just the 15s. I should have gotten a 14. I knew I should have gotten a 14.
The 14 Pro Max, well, entirely, like the entire back was shattered. So then the screen went pure white, so that's why I upgraded to the 15 Plus. And now that's fucking up. So now I gotta upgrade to the 16 or get another 15 Plus.
Or get a different brand of phone because Apple is bullshit.
I don't know how y'all deal with the Edwards.
I did. The phone that I'm getting, the new phone I'm getting, this is gonna be the first or second Android I've ever had. I live on Apple too. Ask me. I don't know how to do anything with them. The settings app is so freaking confusing. It's annoying. Everything is so straightforward on here with settings. Not with Samsung.
What's so different about the 16 series and the 15 series?
Oh, nothing. Oh, like, yes. Because there's a button on the side where you can open the camera.
Oh, it's just a button. They
Yeah.
just said everything was buttons.
Yeah, and my boyfriend has a Samsung. He showed me that his phone does the same exact thing with the button for a camera. Yeah. But it's built into the power button. So every new thing that Apple's coming out with is something that another company has already done. It's not new.
All right.
He has the 15. And,
The new iPhone comes out every year, just like the new Diary of Wimpy comes out every year. Around the same time, too.
it's gonna be really
All right. Everybody ready to get started again? Okay. So we're going to learn how to provide Peri care to an incontinent female patient. So for the test, this is going to be performed on a female resident. Peri care is also done on males. Male Peri care has a lower infection risk. So because female Peri care is a higher risk, they're going to have us demonstrate female Peri care techniques so that we can show that we understand how to avoid giving the patient an infection. So every principle except for shoe rules is used here, all of them. This is a longer skill. Somebody with your level of experience should be able to do this in 17 minutes. It is going to be done on a mannequin. That mannequin will be in bed. You're going to talk to the mannequin just like she's a real person. You're going to provide privacy just like she's a real person. And you're going to tell her all the steps you're going to be doing just like she's a real person. The evaluator will play the voice of the mannequin. So you will get responses, but they'll come from the evaluator. I have a video on this. All of the principles are spelled out here. And this is the short version of how the skill is going to be done. All right, so if you go to page 153, at the bottom, you can see all of your supplies. At the top is the care plan. Care plan tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. It's a miracle. It doesn't happen like that in a clinical setting. You're probably going to have to change the gown and the bedding too. But the test is going to make some allowances. Because this is a mannequin skill, it tells you that the pad is wet, but it's actually not going to be because the mannequin doesn't wet. Step-by-step instructions will tell you exactly how to do that. But let me explain to you a little bit about incontinence. And in order to understand what incontinence is, we have to talk about a normal elimination system. So most people have two kidneys. Those kidneys filter blood and produce urine 24 hours a day. Never stops. Those kidneys are always working. So the kidneys filter the blood, produce drips of urine. Those drips go down tubes called ureters and collect in the bladder. The bladder is nothing more than a Ziploc bag that holds urine. There's a valve at the bottom of the bladder that holds that urine in. When the valve is closed, the bladder fills. When it's full, it rings a bell in your brain, says, hey, we got to pee. You go find a bathroom. That valve opens and the urine comes out. After you urinate, the valve closes again, and now your bladder is ready to refill with urine over the next several hours. This is a normally functioning urinary system. When we have incontinence, all of this is still the same. Your kidneys still filter blood 24/7. Those drips still go down tubes called ureters 24/7 into the bladder 24/7. What is broken is the valve. So those drips of urine are not going to stay in the bladder and accumulate. They're going to come right out of the patient. So when you have an incontinent patient, your patient's going to be wet all the time, 24 hours a day, drip, drip, drip. If you have a patient who is dry, 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 really, really wet, this system works. That valve is holding urine in the bladder. What you have is a staff member who's not getting that patient up to the bathroom. That is not incontinence. So when we have true incontinence and our patient is wet all the time, drip, 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 because that valve isn't working, we have to think about the effects on the patient. So because this urine is leaking out 24/7, drip, 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 that skin is going to be exposed to this urine 24 hours a day, drip, drip, drip. Adult urine is not like baby urine. Baby urine is going to be very mild because babies are fed formula and rice cereal, and they aren't eating a lot of acidic things. They aren't on medication that's going to change the pH of the urine. Adult urine is not like baby urine. Adult urine is acidic. What do you think happens when you hold acid next to the skin? It burns the skin. Acid will burn. So when we have an adult patient who is incontinent and dripping all the time, if you hold that urine up next to the skin for long periods of time, it's going to eat into the skin and cause rashes and wounds and infections and other problems. When they are out of bed, your incontinent patients will probably be wearing an adult brief. We don't call them diapers. Sometimes you'll hear them called depends, but an adult brief or depends. When they're out of bed, this is appropriate. But these are problems because they're waterproof. They're designed to hold the urine in and not leak on everything. That's also going to hold in body heat and block out light. So now we have acidic, warm, dark, moist. That's a problem. So when we have an adult brief on a patient, we have to clean them and change them every 2 hours around the clock. Around the clock. So yeah, I'm changing this person at 2 a.m. and at 4 a.m. and at 6 a.m. and at 8 a.m. every 2 hours around the clock. Don't let them sleep through the night thinking you're going to, help them, because that acid is going to eat into the skin. Super important. But if your patient is in bed, having that adult brief, holding that acid right up against the skin isn't the best option. Sometimes your patients will be put what we call open to air. They're put on a pad on the bed, no adult brief. They're open to air, and the urine comes out of the body and spreads along the pad. That pad helps move the urine out away from the skin, so they're not going to develop as many skin issues and infections. So some of your patients will have a care plan that says adult brief, clean and change every 2 hours. And some of your patients will be in bed open to air, which means they're on a pad, and we're still going to clean and change them every 2 hours. And that's what we're doing with this skill. Our patient is on a pad open to air. Not all patients will be comfortable for this. With this, we follow the care plan. It's up to the nurse to figure out what the treatment plan is. We just follow it. But let's think about that pad for a second. That pad is going to have urine. Now remember, urine comes out of the body. Our body temperature is about 98.6. Urine is actually a little warmer than that because it's held where our furnace is, where we're burning all those calories. So urine coming out of the body is about 101, 102 degrees. It's warm. If you remember me talking last week that room temperature always wins. So when this 101 degree urine comes out of the body and spreads along that pad, it's going to meet air temperature, room temperature. That pad, that urine is going to cool down very quickly. And that pad is going to feel cold, wet, probably a little slimy to your patients. If you were laying on that pad, what would you want done? Yeah, change. Yeah, absolutely. So because of comfort, we're going to change that pad at the very beginning of this skill. Get them on a clean, dry pad. But we've got a wet butt on a clean pad. So at the end of this skill, we're going to wash the front and wash the back, because remember the butt's laying on the pad. And at the end of the skill, we'll change that pad out one more time. So we have a clean bottom on a clean pad for the next 2 hours. This is a washing skill, so all of our washing rules apply. We don't add soap to the basin. We're going to use a paper towel to turn the water on, and we're going to check it. Should feel warm, not hot, not cold, just warm. We ask our patient to check it too. Remember, we're going to treat that mannequin just like she's a real person. So we're going to ask, would you like to check the water temperature? The evaluator may put their hand in that water to check it. So make sure it truly is warm. We're going to use the leaves method for wet body openings. Whatever we wash, we rinse. Whatever we rinse, we dry. And we don't want to get our surface wet, which is why we have a pad under the patient. So this is just showing you all of those steps we just talked about. So no soap in the basin, paper towel to turn the water on, check the water, have the patient check the water. If it gets cold or soapy, we're going to change it out. We're going to use our leaves method. We wash, then rinse, then dry. And we're going to use the leaves method for wet body openings. I'm going to come back to this in just a second and explain this. Change the water if it's cold or soapy. Dry surfaces remain dry. We're not going to use lotion for this one. So our care plan says female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. So for this skill, we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to do peri care. So let's stop there for a second. You can introduce this skill in any way you want to. You can say, I'm going to do peri care. You are never the first person to do a skill, ever, on the patient. If this patient is all of a sudden, right now, incontinent for the first time ever, is that normal? CNAs do normal. So if they're brand new incontinent, first time ever incontinent, that's a nursing job because the nurse has to explain all this to the patient. So you can go in and tell the patient, I'm going to do peri care. They will understand what you're talking about because it's not the first time the skill's been done. But you could also introduce it in more informal terms, like I'm going to do personal care. I'm going to clean you down below. You can use terms like that, but you want to remain professional. You don't want to say something like, I'm going to clean up your hoo-ha. We want to remain professional here. But you can introduce this in any way that you would like. So we're going to do our opening. We're going to wash our hands, get our barrier, get our supplies, and then get our water. We'll use a privacy blanket over the patient. When we're all ready, we'll put our gloves on. And remember, the first thing our gloves should touch is the patient. And then we're going to change the chucks out from under the patient. The way we change the chucks is just like changing a sheet. Clean rolls toward me, dirty rolls away. So it's the exact same process. It's just smaller. It's not the big sheet. It's just a little pad. Same process though. Once we get the patient on the clean pad and we're ready to start the skill, we're going to roll that blanket up and roll the gown up inside the blanket so that when the patient is exposed, we're only exposing the area we need to. And we'll drape a towel over the patient's legs. So the patient should look like this when we're ready to do the skill. This is way more comfortable for the patient than just being exposed to everything. You want to minimize exposure when possible. We'll bring our washcloths out, and we're going to clean using the leaves method. So if I have a washcloth that I've wrung out, and I've applied soap to 5 leaves. So soap, fold, soap, fold, soap, fold, soap, fold, soap. I have soap on all 5 leaves of my washcloth. I'm going to hold her open using my other hand. Just hold her slightly open just a little bit so I can get down the center. So I would put my hand up here, hold her open, and go straight down the middle and move away and fold that over. Do not go down and then back up because of infection control. Pathogens are down in the rectal area, the anal area. We do not want to bring those pathogens back up to the urethra. Urethra is a very short tube that goes from the bladder to the outside world. It's about as long as your pinky. That's it. For female urethras, it's about as long as your pinky. Bacteria can climb that easily. That's a day trip. We don't want to bring bacteria up by the bus loads to the bladder. So we're going to hold open, go straight down the middle, move away, and fold that over. Now I'm going to clean the outside, top to bottom, one direction only, fold it over. The other outside, top to bottom, fold that over. Skin fold, top to bottom, fold that over, skin fold, top to bottom. This will be set aside, and then I'm going to get another washcloth to rinse. Remember, we always move top to bottom, never back up, ever. After we wash, we rinse the exact same way. We get a clean washcloth, we wring it out, we use our leaves method, we hold open, top to bottom, fold it over, top to bottom, fold it over, top to bottom, fold it over, skin fold it over, skin fold. And whatever we rinse, we dry. So I'm going to take the towel and just dry top to bottom, not going back up, one direction only. Pat dry. Once you get the front cleaned, we're going to cover her back up. Privacy is important. Scoot her toward us, roll her on her side so that we can get to her back side. When we have her on her side, there's a chucks under her. We're going to take our clean washcloth that we haven't used yet. We're going to wring it out, and we're going to soap 4 corners. So I'm going to spray soap, fold, spray, fold, spray, fold, spray. Now I'm ready to wash. I'm going to wash from the anal opening up that center crease. I'm going to fold that over. Clean leaf. I'm going to clean one cheek off, fold that over. I'm going to clean the other cheek off and fold that over. And with the last leaf, I'm going to go right up that center crease again, because that kind of is like a riverbed. All the urine's going to go up that crease. So we're going to clean it twice, once at the beginning and once at the end. We'll set that aside. We'll get another clean, wet washcloth, wring it out, because whatever we wash, we rinse. So I'm going to take my washcloth. I'm going to rinse from anal opening up, fold it over, one cheek, fold it over, the other cheek, fold it over, and once more up the middle. Whatever we rinse, we dry. So I'm just going to dry, moving upward, one direction only. And then we'll change that chucks out again. So clean bottom on a clean pad. Not too bad, right? This is actually a pretty easy skill. So once you understand all the components to it. So after we do that, we'll have our patient in the middle of the bed on a clean pad covered with the blanket. We're going to take care of all of our dirty stuff. We're going to put our dirty linens in dirty linen. We're going to clean our basin and put it away, get everything cleaned up, and then we can remove our gloves. After we put our soiled linens away and we clean our basin and store it, then we can remove our gloves and remove the privacy blanket. Always make sure the patient is covered. Then we'll do our closing. That's the skill. Now, in your book, we do have male pericare. It is discussed on page 154. Yeah, thanks. 154. Second column says, what about male pericare? Male pericare, you just clean what you see. You start at the tip of the penis, go down the shaft, clean the scrotum, should take no more than 5 seconds. You rinse and you dry. If the male is uncircumcised, you do have to retract the foreskin to clean under it. We always put everything back where we found it, so put that foreskin right back where it was when you started. It shouldn't take long to do this skill on a male. Everything is right there out in the open, easy to get to. Don't sightsee. Get in, get it done, and move along, okay? Now, the reason for that is it doesn't take a genius to figure out you got warmth, you've got wet, and you've got a human hand. If you're there too long, you're going to get a reaction. It's just physiology, okay? So you want to try to minimize discomfort for them and you. This is way quicker on males. But the thing is, we don't do as much male pericare as we do females. Male genitalia is right out there out in the open. It's up front. It's easy for them to reach. And remember, patients that can do a skill will do the skill. And so most males are able to take care of their own personal cleaning needs because everything is easy to reach. Females, however, their genitalia is kind of tucked up and under and harder to reach. So we tend to do more female pericare than male pericare. If at any time you're uncomfortable, you need to let your nurse know. Okay? Good? Okay. All right. This is our last skill for today, and then I will give you your review sheets. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do pericare. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm. Not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink, rinse the basin, pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done.
All right. Any questions? Any questions? So all of the skills that we needed to cover today are done. On Monday, we will have 3 skills to do. We'll have catheter care, which is a version of this. We'll have emptying the drainage bag, which is a 4-minute skill. And we will have another range of motion, which, I'm sorry, assisting with a bedpan, which is another toileting skill. So nothing very hard, nothing to worry about. On Monday afternoon, we will also have our last CPR class of this class. So if you do not have your CPR BLS and you need it, that would be a good time for you to get it. It'll be $45. After graduation, any future CPR classes will cost you about $55. Monday. Yep, you can pay when you come. You don't have to pre-sign up. You can just come. Let me see here. And Tuesday will be the game show as well. Wednesday's graduation. We're almost there. You guys are doing good. All right. Does anybody have any final questions for me? Rest of the class will be practice. You're free to stay and practice. Those of you who need to go to prepare for the storm, I completely understand. I will see you on Monday. Remember that I will not be in tomorrow.
All right. So everybody stay safe. Those of you who joined virtually, stay safe and happy caregiving. Bye.